Simply Modified, we are shining a light on the complexities of dysphagia. In our series Dysphagia Bite, we speak with passionate individuals who are at the heart of dysphagia care to share their practical insights, emerging ideas, and real stories from the field. These bite-sized interviews are designed to inform, inspire, and connect us all in the shared goal of better mealtime experiences. In this episode, we're exploring dysphagia after stroke with speech pathologist Chantelle Hutchinson. A reminder that these interviews are for general education purposes and don't replace medical advice. If there's one message to take away from this, it's that dysphagia is highly individual, so be sure to connect with your own healthcare team for personalised support. Okay, so welcome to another episode, and today we're zooming in on dysphagia and stroke, a common but complex issue that can impact everything from nutrition and safety to identity and connection. And to help us explore this, we're joined by Chantelle Hutchinson, a passionate speech pathologist who has spent a lot of her career supporting adults with acquired conditions following a brain injury. Chantelle currently works in a neurological rehab outpatient clinic where she supports many clients that are recovering from stroke or living with progressive conditions. She not only has years of clinical experience in community rehab, but also has a love of sharing knowledge, including designing a curriculum and teaching that curriculum to students at La Trobe University. And when she's not in clinic or the classroom, Chantelle runs a popular dysphagia-focused Instagram page called Dysphagia Community, designed to support and inspire fellow speech pathologists. Hi, Chantelle.
Hi.
Thanks for joining me today. I have been a big fan of yours for a long time, especially in that Instagram space. So it's really nice to connect with you, and thanks for jumping on today.
Yeah, no worries. Thank you very much for asking me. And I've been a big fan of your page as well.
Thank you. Okay, well, let's just start by chatting a bit about your speech pathology career, because as I gave a bit of info in that intro then, it's clinical, but there's also a lot of non-clinical practice that you really support other speech pathologists in, be them students or be them practicing speech pathologists. And where does your passion for dysphagia come into all of that?
Yeah. So I think it started in a previous role of mine, so maybe about 4 or 5 years ago, and there were sort of multiple factors that were happening all at once that sort of played into me becoming quite interested in dysphagia. One of them was I'd started a team lead role in a large private practice and was supporting a lot of junior clinicians coming into the practice. And I was really finding that dysphagia was just one of those areas where they didn't have a lot of confidence in. And there was this real sort of gap between, what the research was saying and what we were doing as therapists. It was also about this time that I discovered Instagram as well, and all of the education that was being posted on Instagram. And funnily enough, I was finding out about things a lot quicker than I had, previously done when I was just reading the research. And another thing was we were doing a lot of quality projects related to dysphagia at this role as well. But I was leading a lot of those projects, and so all of these things just I ended up sort of deep in dysphagia stuff, and I've just been passionate about it ever since then.
Brilliant. And I feel like both our trajectory into the dysphagia space was quite similar. There's such, like you said, a big disparity between what we're taught at uni and practicing that. And our confidence as clinicians, obviously it grows over time and with experience, but I feel like there's that really big gap in the resources to make that really applicable as clinicians. Like, what do we do? And you're right, of course, we're always leaning towards that best practice and going into the research to explore that. But that dissemination of that providing information to clinicians, sometimes it takes so long for that research to get there. And by using, all of the wonderful things about Instagram and all the social media, sometimes it just helps make that information come across a lot quicker. So that's brilliant.
And a lot of researchers are on Instagram, so you're getting it from the source as well, and it just provides it in a way that's just digestible as well. It's not a big, long 20-page research article. You can get just chunks of information that's just a lot easier to take in.
Yeah, brilliant. And something that is obviously your support gearing that information towards clinicians is brilliant. And I guess it works so well with this podcast with Simply Modified because that's gearing it towards the people with dysphagia and their families. So, yeah, again, thanks so much for being here.
No worries.
Okay, so let's explore a little bit about dysphagia and stroke. So, if someone experiences a stroke, obviously the first thing that they usually do is get admitted to hospital, right? So after a loved one has maybe experienced a stroke and they're within that hospital environment, what are some of the swallowing changes that can occur, and what might families first notice in that hospital environment that are happening, and how treatment can start?
So there can be lots of different symptoms, I suppose, when it comes to swallowing. So it can be individual to the person, but a few, obvious ones might be that someone is coughing when they eat or drink, or they're clearing their throat after they swallow something. It could be something less obvious, like maybe they're needing to take multiple swallows when they're having something to eat or drink. And something that, families can be really helpful with is letting the speech pathologist know what's different compared to before, because for some people, maybe they're taking a really long time to eat or drink something, whereas before they used to be quick. Or maybe they have always been really quick to eat and drink, and, it's the opposite. And these are things that, clinicians are not necessarily going to know. So really helpful if family can, point those things out.
Yeah, brilliant. And those subtle changes, it might not be a really big impact, but those subtle changes are still really important for us as the treating team to know. And you're right, having that, what we call like a baseline, so what they were like prior versus what they might be like now after exploring that stroke. Really good info to have. Okay, so say something like that has been flagged. The family said, there's a few changes I'm noticing around their swallowing. It seems a bit different. What can families or that client expect in terms of assessment within the hospital space?
Yeah. So I think according to the stroke guidelines, I think anyone who has a stroke needs to have a swallow screen done within 24 hours anyway. And this can be done by a speech pathologist, but it could be done by a nurse, for example, as well. It just depends on the hospital that you're in. So normally this swallow screen is something that's fairly quick and brief. So it might involve someone just asking a few questions, doing some observations of maybe, how the person is sitting up in bed. Is their posture upright, or are they leaning? And it might involve giving them a few quick things to maybe eat or drink. And then depending on the results of that, will determine the next step. So if they fail the swallow screen, for lack of a better term, then usually that means that a speech pathologist will need to do a full assessment. And a full assessment is just a bit more comprehensive. So that speech pathologist will probably have a look at the medical file, ask a lot of questions, probably do an assessment to see how all the muscles are working in the face. And then we'll get the person to normally eat and drink multiple things to see how they go. And then again, depending on the hospital and depending on the protocols, they might have additional assessments. So we call these instrumental assessments. So it could be a video fluoroscopy, which is also known as a modified barium swallow in other states in Australia. And that's just like a swallow x-ray that provides like a video of what's happening. Or it could be something called FEES, which is when they pop a camera through the nose and have a look. So not everyone will need to have one of those. It will depend on the particular problems that person has, or again, the facilities of the hospital, because not every hospital will have those facilities.
Yeah, well said. And we have a little bit more information on those instrumental type assessments and what people can expect in another episode as well. And you're right, there are so many disparities or kind of variations in stroke care. Obviously, a lot of us are governed by those clinical stroke guidelines that continue to get updated and tell us about that research and what's expected. And hospitals try their best to uphold those guidelines. But of course, it does depend on the capacity of the clinicians, the type of hospital, where it's based, etc. Yeah.
Yep.
Okay, so let's talk a little bit more about the relationship between stroke and dysphagia and why dysphagia can occur quite a bit in this population.
Yeah. Yes, that's a really good question. So I guess the reason why dysphagia is so common is because swallowing, although we probably don't think too much about it until something goes wrong, it's actually very, very complicated, and it involves multiple areas of the brain. There are different symptoms or issues that you might have after a stroke. So, for example, you might have some vision problems, and normally that's sort of correlated to a particular area of the brain. Whereas with dysphagia, there are so many areas that are involved. I guess there's lots of places for things to break down. So, for example, there's, an outer layer of the brain, which we call the cortex, and that's involved in swallowing. There's deeper parts of the brain as well that we refer to as subcortical areas. Or there's the brainstem, which is like the back part of the brain that connects to the spinal cord. And all of them have different roles in terms of, sensing, what it is that's in our mouth, how big it is, what the temperature is, and that sort of tells us when to start the swallow. And things should occur in a nice sequence in order, but that doesn't always happen. So it really depends on what part of the brain is affected, and that will really determine the kind of swallow problem. But yeah, that's why it is so common, is because it involves so many parts of the brain.
Yeah, well said. It is. It's such a complex process. Obviously, the brain has so many different functions that it's constantly working on to help us move around and be who we are. But when a part of that brain is, I guess, impacted either by the stroke in a big way, by a small way, because it's so complex, I guess in our assessment, we're really working with the medical staff to say, okay, where did that stroke occur? How big was the impact, and how's the recovery looking? Because when the brain does start to recover as well, I guess the dysphagia or the swallowing impairment starts to change as well. So I guess as speech pathologists, we're constantly working with that medical team to say, okay, how's the brain functioning? What's it all looking like? Because that tells us a lot and informs us a lot about the trajectory of what that dysphagia could look like long term as well.
Yeah.
So coming into management, maybe especially in the early stages of recovery for stroke, clients or families might look at some modified textured diets or fluids. So this is where things like changing diets can really come into it. Can you tell us a little bit about what families might expect within a hospital and what that looks like?
Yeah, so there are different levels of diet modifications, and same with fluids as well. So it's starting from, we have our normal thin fluids, which are things like water, and then we can go up to a slightly thick consistency. So this might be, even some juices might be this consistency naturally, and then it goes up to mildly thick, moderately, and extremely thick. So depending on, the type of swallow impairment and how severe it is, might determine what kind of consistency the fluid is. And same with food. So there are different levels of diet that will be served in the hospital. So it starts at a puree diet, which is, really smooth, no lumps. And then it goes up to a minced and moist, which has small little lumps. Then it's onto a soft diet, which should be soft foods, and that's normally cut up to reduce choking risk. And then we go on to normal foods. So I think all diets in Australia will follow those guidelines, which are referred to as IDSI. And so normally if a speech pathologist is recommending a change, they will recommend a certain level of diet and fluids, and then all of the meals in the hospital will be served according to that consistency.
Yeah, brilliant. And I guess knowing that what families can expect, there might be some changes. Your loved one might start on a particular diet level or fluid level, but with speech pathology support, that might be changing a lot over their inpatient stay, or what it might look like as an outpatient as their journey progresses through. So lots of changes can occur. What can families know in terms of their role for advocating or understanding these changes? What would you like families to know to help those discussions within the hospital space? Because sometimes they can feel like, oh, it's all out of my hands. Things are just happening and changing. What can families do to help gain some of that control within their caregiver role in the hospitals?
Yeah. So I guess one thing I just want to mention that you said, Bree, which is really important to keep in mind, is a lot of the time these things are just temporary. Not always the case. So some people will have, chronic long-term dysphagia, but a lot of the time, although these recommendations have been put in place for now, what we find after stroke is after it initially happens, things usually improve. So hopefully those diet or fluid recommendations aren't forever. But I would say just try to get involved in discussions with the medical staff and speech pathologists, because they do want to make these decisions collaboratively. And like I said earlier, they don't know the person like you do. So giving them information about, if the person can't communicate as well as they used to, it's really important to let the staff know what this person would have wanted or their preferences to help sort of make the decision, because it's not always about diet and fluid modification. There are other things that can be done as well. So ask about those other sort of management or intervention techniques too.
Brilliant. And that kind of brings us into the next one, because modifying diet and fluids is usually only one aspect of the support we provide as speech pathologists within that hospital space. What are some of the other treatment options that speech pathologists will usually help explore for that patient that's in that recovery stage?
Yep. So one thing might be the use of adaptive mealtime aids. So they might work with an OT on this one. So this could be something like using adaptive utensils, because maybe it's harder for the person to feed themselves now. Or I had one client who took a really long time to eat a meal after their stroke, and so their meals were going cold. So we recommended getting a heated plate, for example, to keep their meals warm. So it could be things like that. Or it could be compensatory strategies, for example, swallowing a different way. So sometimes a common sort of head posture that might be recommended for someone who's had a stroke might be a head turn to one particular side if they have weakness on one side of the body, and swallowing in that way can be safer or easier, or it could be, popping the chin down. But these are things this is where we need to have that instrumental assessment. So a speech pathologist will want to see what the swallow looks like with a head positioned in a certain way to tell if that's going to help someone or not. Or another thing that can be done is swallow rehab. So just like someone might do exercises for their arm or for their legs, you can do exercises for the swallow as well to help improve the swallow function.
Yeah, exactly that. So sometimes there's compensatory strategies, more about the positioning or, again, the texture modification, or there's those rehab strategies to help bring that strength or coordination back. Again, as speech pathologists, we really rely on those instrumental assessments to help inform. We don't have the X-ray vision, so it helps give us that better understanding of what approach will work. But of course, as families, bringing that up with your team, if you're feeling like maybe a service is lacking or you want a little bit more, stay open and advocate as much as you need if you're feeling like you want to explore some of that with your loved one while they're there.
Yeah. And just asking questions like, are there other assessment options available? Are there other treatment options available? So you don't have to know them, but just asking those questions might be a good first step.
Yeah. And gosh, after a stroke, loved ones are taking on so much. The information that they're trying to absorb, speech pathologists are one thing, but you're right, it's often after a stroke that they're seeing an OT, a physio. There's a lot of team around you, so it can be overwhelming, but don't feel like you can't revisit these questions. If you ask them the week prior and you've forgotten, raise them up again so that you can feel super informed going forward. And this kind of brings me to my next part. What can clients or family members expect when their loved one is then discharged from hospital? Their dysphagia or swallowing impairment is still present, or to some degree. What can family members expect in terms of that home life now?
Yeah, so I guess just really important to feel like you're confident in knowing how to manage it at home and things to look out for. So I guess just if the person needs, assistance or supervision, just making sure that there is someone available, or if they need modified textures, just making sure that you know how to prepare those, or where to purchase them from, I suppose, because you can get pre-made meals and pre-thickened drinks and things like that. And I guess just knowing when the person leaves hospital, just feeling like you're confident in knowing what signs you need to look out for in order to get help again, because it's going to be different for everyone. So if there's a change from how the person normally swallows, then you'll want to know, well, when do I need to contact the speech pathologist to come for a review?
Yeah, well said. And those changes, they're to be expected. The way that they are at discharge from a hospital, your loved one is likely to change a lot as soon as they get home. And these things, it can put a lot of strain on that caregiver. So just feeling that confidence to know, okay, actually, I might have to re-refer or get some extra support. What can a speech pathologist do after that person has been discharged from hospital? Like, are they expected to be on their own, or where can they get that extra support from?
Yeah, so usually the speech pathologist who sees someone in the hospital will usually refer on to a community-based speech pathologist. So that will be a speech pathologist that will come into the home normally, or perhaps they've referred someone for an outpatient appointment. So that's where they'll come into a clinic to see a new speech pathologist, just really depending on the services available and what that person needs. So that speech pathologist, let's say they're coming to the home, they'll be able to do their assessment there, but also help you I guess they can be a little bit more hands-on, so they can show you how to prepare the meals or how to thicken the drinks if you're not really confident with that. And like Bree touched on as well, there will be things that pop up at home that haven't shown up in hospital, because there are a lot more variables or distractors and things that are happening at home, whereas the hospital is a much more controlled environment. So yes, it's not unusual if you find that, oh, hang on, this person seems to be struggling a lot more at home because maybe, people are talking to them, or maybe the TV's on. It's just completely different.
Yeah. The environmental, the variability in the environment is so different than your clinical hospital setting. It's going to create a lot more differences in that mealtime. Mealtimes are often experienced, with other people, or it's quite social in nature for some cultures as well. And that brings a lot of differences than your regular, hospital ward, for example. So, yeah, big changes there. I guess the key thing, though, is just keep in touch with that speech pathologist. If obviously there's a bit about accessibility to services there, but if there are services available for you, make sure that you're reaching out to get that support the whole way through your journey. Now, I just thought at the end here, we'll kind of touch on two different journeys, because stroke really depends on, the size of the stroke or the impact there, once again, about the brain. So where it was, that it was localized, and how big that impact was. For some people that have had a really good recovery from their stroke, we'll start there. What can people look out for in terms of those signs and symptoms that are really positive signs to say that, okay, your dysphagia might be resolving? What can people look out for there?
Well, I guess just a reduction in any symptoms that were present initially, I suppose. So, if you were coughing a lot, for example, or throat clearing a lot, and now that's reduced or it's gone, hopefully that is a good sign that the dysphagia is no longer there. Some other things that might not be as obviously related to the swallowing, perhaps it might be about, putting on weight. So maybe the person has lost a lot of weight because they weren't able to swallow as well. So putting on weight, or maybe the person is now really well hydrated, for example, or maybe the person is going out more. So sometimes people can feel really, self-conscious or embarrassed about their swallowing problems. And so they're not, say, going out for coffee or going out for lunch as much as they used to. So maybe socializing more around these meal times might be another sign that things have gotten a lot better.
Yeah, and you're right. Sometimes we take like a very clinical lens where we're just focusing on those little signs or the big signs and symptoms around the swallow. But sometimes it's actually about stepping back and looking at, like how's your confidence when you're out and about? Is that improving? Are you able to get that coffee with the friend that you used to love catching up with? And those bigger like quality of life changes can sometimes be the really nice indicator for us to say, you know what, that recovery is looking really good for you.
Yeah. And it's quite often with people who have more mild dysphagia, we may not see anything that's different when we do our assessment, because it's more about, like you said, how the person is feeling. Maybe it's just that swallowing feels easier now, but we're not necessarily going to see things as a speech pathologist if we're just watching someone eat or drink.
Yeah, we always need to take account for that bigger picture.
Yeah.
Okay, now what about for someone that has had a really big stroke and maybe their dysphagia is still quite present and maybe looking like it will stay around long term? What does management look like there? And maybe, I guess, like the support and things that people can look out for or seek out to better support long-term dysphagia?
Yeah. So I'd say with this population, this is where it's really important, I suppose, for, the person who's had a stroke and their family, just to be really well educated and informed, because quite often, it's the family and the person with dysphagia who really become the expert in managing the dysphagia. It's not necessarily the speech pathologist, because they've been living with it for so long. I lost my train of thought there.
No, that was brilliant. I feel like I understand that a lot, that whole idea of like changing, we're the clinical expert, we're the speech pathologist, but actually putting that onto the person that's experiencing the difficulties and their family. Sometimes I'll have a consult with someone, 3 or 4 years post-stroke, and they're like, oh, you know what, here's some cool tricks that I've been using and it's really helped us a long way. And everyone's management is so individualized. Like as speech pathologists, of course, we're here to help you navigate it, but we don't always have that magic wand as much as we want to. And it's because everyone's experiences are so different. You're right. Sometimes as clinicians, we really need to remember to really listen and pull apart some of those strategies that people are using, because it's so beneficial as putting their role as expert into play.
Yeah. And the other thing I just want to touch on as well, so for people who have had, chronic dysphagia, things can still change down the track. So even though you might be living with dysphagia long term, it doesn't mean that some small changes and improvements can still happen. So I just say as well, it can be beneficial to get a review or get a repeat swallow x-ray done, just to see if things actually have improved, because it can happen. And Brie, I'm sure you've come across this as well, that we might see someone who's been on a really heavily modified diet for years, and when we do an assessment, we actually see their swallow has actually improved quite a bit over that time. So maybe the recommendations can change.
Yeah, well done. There's always room for movement there too. And I guess you're right. Like, come back to your speech pathologist and your team if you've got that inkling to think, I've been managing this modified diet quite heavily, like you said, for so many years. I just have a feeling that there's been some changes since then. Can I get another review and a proper assessment done? And that's all valid reasons to have that assessment too.
Yeah. And I guess, things are always changing in terms of research as well, and new things are coming out. So perhaps, there might be some new sort of treatment options that weren't actually available maybe 5-10 years prior as well.
Yeah, definitely. There's some wonderful treatment options that are trickling out into the works that I'm super excited about. So I agree. If you had a stroke several years ago and you're still experiencing dysphagia, reach out and see what other treatment options might be available. Really good point. Okay, well, thanks, Chantelle. That's a really nice kind of summary of stroke and dysphagia. To finish today, can you tell me what would your favourite modified food that could be simply modified in any way that you'd recommend or support to inspire your clients and families with dysphagia?
So one food I have in mind, I don't know if it meets your criteria because it's kind of already modified the way that it's made, but I feel like it's just a really good option if you want to, for everybody to have it, I suppose, without needing to do too many modifications. So it's chocolate ripple cake. I love it. I make it every Christmas. So for those who don't know, it's so simple. It's just chocolate ripple biscuits, whipped cream, and then you put the cream in between the biscuits until you've used all the biscuits in the packet, and you pop it in the fridge to set for a few hours, and it comes out nice and soft and super delicious. So I would normally put things like nuts and strawberries with it, but obviously someone who has a more severe dysphagia, you might want to substitute those. And what I like to do with my chocolate ripple, I only keep it in the fridge for a few hours, maybe like 2 or 3. So it's still got a little bit of crunch. But again, if you want it to be completely soft, keep it in there for I think about 5 or 6 hours and it will be completely soft.
Yum. Love that. I feel like, desserts lend themselves so well for a dysphagia diet. Like I feel like there's always, a cream or a custard or a mousse that really help to soften things, and they're just delicious. So really good choice.
I haven't had lunch yet. I've just made myself hungry now.
Go make some chocolate ripple cake.
Yeah.
Okay, well, in terms of all the wonderful work you're doing through Dysphagia Community and Dysphagia Bite, where can people find some really wonderful resources that you're putting together?
So I'd say go to my Instagram page, which is at Dysphagia Community. So I've got links in there to some handouts that I've created. So there are a few handouts that are for clients. So for example, oral care is really important if you have dysphagia, or some fact sheets as well, like dysphagia with certain conditions. So yeah, definitely Instagram is the place to find me.
Brilliant. Well, thank you so much, Chantelle. And of course, everyone head over to your Instagram page, Dysphagia Community, for more info. But if you enjoyed today's conversation, keep an eye out for more episodes that'll roll out soon. And thanks for listening. As always, if you have any questions, reach out. I'm always happy to help, but I'm sure Chantelle, if you have any questions for her, would also be happy to answer if you reach out via her Instagram. Thanks for joining us. Stay tuned for more episodes. And remember, dysphagia is different for everyone, so reach out to your healthcare team to find what works for you. Check out the Simply Modified Whole Foods Cookbook for more dysphagia inspiration, or you can reach me at Network Speech Pathology.